Arrhythmias are among the most common yet challenging clinical problems we encounter in medicine. For a medicine student, it is absolutely essential not only to identify the arrhythmia but also to approach it systematically, from recognition to stabilization, diagnosis, and long-term management. In this session, let us walk step by step through the approach to arrhythmias. So, step 1 is initial assessment, ABCD. So, whenever you see the patient with suspected arrhythmia, the first step is always to assess patient's hemodynamic status. Check airway, breathing, circulation, look for blood pressure, oxygen saturation, pulse volume, and mental status. Ask yourself, is the patient stable or unstable? Unstable features include hypotension, chest pain, altered sensorium, syncope, or shock. If the patient is unstable, immediate resuscitation takes priority over making a precise diagnosis. Now, step number 2, that is basic monitoring and investigations. So, once the patient is stabilized, quickly attach them to cardiac monitor and the 12-lead ECG. Check the rhythm strip to identify rate, rhythm, and QRS beat. Now, take blood samples for electrolytes, renal function, cardiac enzymes, and thyroid function, as a metabolic causes often precipitate arrhythmia. Step number 3 is rhythm recognition framework. So, to systematically analyze any arrhythmia, we use a structured approach. Number 1, rate. Is it tachycardia or bradycardia? Number 2, rhythm regularity, regular rhythm or irregular rhythm. Number 3, QRS beat, narrow complex or broad complex. Number 4, P wave presence and relation. Are P wave visible and is there any heavy dissociation? So this simple 4-step method helps to narrow down the possibilities. Now, step number 4 is approach to bradyarrhythmia. So if the heart rate is less than 60 beats per minute, think of bradyarrhythmia. So first assess symptoms like syncope, dizziness, or hypotension. Look at the ECG for sinus bradycardia, sinus arrest, sinus AV block, or escape rhythms. Immediate management depend on symptoms, like if symptomatic patient with hypotension or shock, give IV atropine. If atropine fails, consider temporary pacing or dobutamine or isoprenaline infusion. Always look for reversible causes like drugs like beta blockers, digoxin, electrolyte disturbance, or ischemia. Number 5 is approach to tachyarrhythmia. So if the heart rate is more than 100 beats per minute, it's a tachyarrhythmia. So now classify using QRS beat and rhythm regularity. So number 1 is narrow QRS, that is less than 120 millisecond, that is 3 small boxes. It is usually due to supraventricular. So regular narrow tachycardia, think of sinus tachycardia, AV-NRT, AV-RT, atrial flutter with fixed block. Irregular narrow tachycardia, think of atrial fibrillation or MAT, that is multifocal atrial tachycardia. Now 2 is broad QRS, that is QRS more than 120 millisecond or more than 3 small boxes. So it could be due to ventricular or supraventricular with aberrancy. So regular broad tachycardia most often due to ventricular tachycardia. So always treat wide complex tachycardia as VT unless proven otherwise. Irregular broad complex tachycardia, think of AF with bundle branch block or pre-excited AF. Now step number 6, that is immediate management of tachyarrhythmias. So in unstable patient with any tachyarrhythmia, whether narrow or broad complex, the first line treatment is synchronized DC cardioversion. For stable patients, like with narrow regular, try vagal maneuver followed by IV adenosine if no contraindication. Narrow irregular like atrial fibrillation, we have to control rate with beta blockers, diltiazem or digoxin, and consider anticoagulation if persistent. Then wide irregular, we have to assume it as a VT, give IV amiodarone or perform cardioversion. Wide irregular, avoid AV nodal blockers. If suspected pre-excited AF, use procainamide or amiodarone with caution. Now step number 7, that is long-term management. So once the acute event is controlled, focus on long-term management. So we have to identify and treat underlying causes like ischemia, thyroid disease, heart failure, or structural heart disease. Then decide on pharmacological therapy like beta blockers, calcium channel blocker, or antiarrhythmic drugs. Then consider anticoagulation in atrial fibrillation using CHAD score. Then device therapy, it may be needed in like pacemakers for symptomatic bradycardia, ICD for VT or VF prevention, CRT in selected patients. In drug refractory supraventricular arrhythmias, radiofrequency ablation is a curative option.